can wait for 5 minutes. Oh, so we have a partner about 10 minutes. Chairpersons, and photo moral session chair
website ಅಲ್ಲಿ ಬರುತ್ತೆ ನಾಳೆ ನಾಳೆ ಬರುತ್ತೆ
ನಿಮ್ಮಲ್ಲಿ ಡೈರೆಕ್ಟ್
ಇಲ್ಲ ಅವರು ಇಲ್ಲ ವೆಬ್ಸೈಟ್ ಅಲ್ಲಿ ಬರುತ್ತೆ
I will never ever come to India. What kind of people, what kind of
Okay, what a tagline. Where sports meets wellness. Perfect. Perfect.
May I ask you for the last first step for you? Do you
सब प्रेजेंटेशन मिलेंगे एवरी प्रेजेंटेशन विल बी ऑनलाइन ना जस्ट अपना हाँ हाँ किताब लिया था क्या मेरे पहले HIV पॉजिटिव नहीं मुंबई Christoph हाँ sharing go around. Meka will join us. Just ask.
are not there?
You don't push him like my wife is pushing me. My wife is allowed to take.
Hello, good morning everyone. So we will start our session. I would like to invite our chairpersons for the next session, Dr. Christoph Spinner, Dr. Meka Sathyanarayana. Topic of our session is tailored care, addressing HIV care in special populations. Over to you, our chairs.
Welcomes Dr. Mamatha Lala. Dr. Lala leads
Good morning, everyone. Welcome to the session on the last day of ASICON meeting. Great to have you all here in the early morning. And we are pleased to have the first talk of Dr. Mamatha on current perspectives in ART in children and adolescents.
ASICON welcomes Dr. Mamatha Lala. Dr. Lala leads the Department of Pediatrics at TB Bhava Hospital in Mumbai, showcasing her leadership in pediatric care. Dr. Lala has over 23 years of experience in the field of pediatric HIV, AIDS and PMTCT. She has authored the books on pediatric HIV, including a textbook recommended by Marks, and has over 15 publications. Dr. Lala's expertise spans pediatrics, perinatal pediatric HIV/AIDS, tuberculosis, and infectious diseases. She has received numerous awards for her outstanding work, including the Advika National Award for Women Achievers 2023, the Chanakya Award, and the Daughter of the Year 2019, among others, highlighting her dedication to social service and women's empowerment. We look forward to hearing her talk on current perspectives in art in children and adolescents.
Thank you very much for that introduction. A very good morning to all of you. I am the opening batsman. So let's kickstart the day with a very, very important topic on antiretroviral therapy for children and adolescents with HIV. Of course, this virus has had a tremendous impact on our world for the last 4.5 decades, I must say, and especially on the children who are infected and affected with the virus. Children not only lose their parents and siblings to HIV, many a times they lose their entire childhood as well. They're subjected to immense psychosocial distress in the family and left without adult love, care, protection and guidance. They're subjected to stigma and discrimination and exploited in terms of child labor and sex. Children as young as 6, 8 and 10 suddenly become heads of the household, having lost their parents to HIV and are many a times driven to life on the streets. With inadequate food, shelter and access to healthcare, education becomes a distant dream. We all know that a child gets HIV majorly from an infected parent, an infected mother. But the good news is this area has seen tremendous success in preventing mother-to-child transmission of HIV, and it can be brought down to less than 1%, which is also happening in our country in many pockets. But despite that, the statistics of UNAIDS 2022 still says that we have over 1.5 to 2 million children less than 15 years of age who are infected with HIV. These babies that are born with the HIV infection really have a very bad prognosis if they are not diagnosed early and put on antiretroviral therapy early in life. As you can see, nearly 60% of them do not even reach their 3rd birthday without antiretroviral therapy. So mother-to-child transmission of HIV can be and it should be prevented as far as possible in every single case. Thanks to the antiretroviral therapy, what was in the past a fatal illness is currently a chronically treatable, manageable illness, and hopefully like a proverbial pot of gold at the end of a rainbow, somewhere around the corner we do have a cure. We have very good antiretroviral drugs. We've been hearing about so many of these topics in the last couple of days, and these drugs can stop HIV at all steps of the life cycle. The major categories here, what I would like to highlight are the ones which are in red, which are not yet approved for use in children less than 12 years of age. In this slide, what is glaring is the unequal HIV service access and outcomes globally when you compare the statistics for children versus adults across all the three cascades of 95, 95, 95. In the first cascade, as you can see, the green bars represent the children and the red bars represent the adults. So only 63% of the infected children know that they are infected in comparison to 87% of the adults. Across the second cascade, only 57% of the infected children are on antiretroviral therapy in comparison to 77% of the adults. And in the third cascade, less than half, 46% of children have managed to get a virological suppression in comparison to 72% of the adults. This is the 2023 statistics. So antiretroviral therapy in children is definitely fraught with many, many challenges. It mandates a lifelong treatment for these babies right from the time they are born right up to the end of their lives, which is an entire lifetime. Daily multiple doses, the sizes of the pill, the number, and the most important challenge is the dependency on the adults who have to remember to give the drugs to these children every single day. Of course, the poor pharmacokinetics in the growing child, limited formulations, unpalatable, unavailable, unaffordable, many times if not available in the government program, multiple side effects in terms of immediate, short-term and long-term consequences, and of course, poor adherence leading to therapeutic failures. The first and foremost important aspect before starting any child on antiretroviral therapy is to ensure that you identified a reliable, consistent primary caregiver as well as a backup caregiver, because the success of these children's outcome on antiretroviral therapy for a long time till they can actually take over their own responsibility of taking the medicines depends on the adults who are giving them the medicines on a daily basis. After a baseline clinical and a lab assessment, treatment preparedness of the adult that is going to take care of these children as well as the child is extremely important for a lifelong commitment. The what, when, how and who's going to give the medicines every day, who's going to supervise that the child is actually swallowing those medicines, how should it be given, how many should be given, when it should be given, every single minute detail has to be discussed with the caretaker as well as the child, if the child is able to understand a little older child, and they have to be prepared for a lifelong commitment of antiretroviral therapy. Once all this is done, as you can see, depending on the age of the child and the weight of the child, NACO has the first-line drugs, which is abacavir, lamivudine and dolutegravir, with the 10 milligram dispersible tablet that has been made recently available in the government program. For those children between 6 to 10 years of age with a weight of nearly 20 to 30 kg, it's the same abacavir, lamivudine and dolutegravir in appropriate doses for their weight. For children more than 10 years weighing more than 30 kg, of course it is concordant with the adult fixed drug combination of tenofovir, lamivudine and dolutegravir. Especially children who are co-infected with tuberculosis, we need to remember that initiating anti-TB treatment takes priority over starting ART, but ART also needs to be started as soon as possible, irrespective of the CD4 count, especially in these children. But what needs to be remembered is if the child has any suspicion of meningitis, we need to defer the initiation of ART to 4 to 8 weeks, but it has to be started as soon as possible. And there are some important modifications about the drugs that we need to keep in mind, like how we do in the adults as well. If the child is on a dolutegravir-based ART requiring a rifampicin-based AKT, then the dose of the dolutegravir has to be doubled, and this double dosage has to be continued for 2 weeks after the last dose of rifampicin has been given to the child. If the child is on a lopinavir-ritonavir-based regimen, of course, super boosting in the ratio of 1:1 for lopinavir and ritonavir needs to be done, like how we do with the adults as well. And this super boosting has to be continued for 2 weeks after the last dose of rifampicin has been given to the child. We have a lot of child-friendly formulations, 4 tablets, dispersible tablets, pellets, liquids, syrups, granules, etc. And in our national program, we have a whole lot of child-friendly drugs that are available, which makes it a little more easier to ensure adherence to these children. Of course, the combination drugs as well makes it a little easier in terms of reducing the pill burden. And of course, the older children and adolescents are given the adult tablets. What's very, very important in these children is to ensure that you do a weight monitoring at every clinical visit of this child, because the dosage of the ART, the drug, needs to be modified as per the current weight of the child. A child is growing and on ART expected to put on weight and improve. And if the weight is not monitored on a regular basis and the doses are not titrated, despite a good adherence, which by itself is a big challenge, despite a good adherence, they can land up with suboptimal levels of the drugs and end up with treatment failure. So weight monitoring is extremely important. Along with that, of course, supportive therapy in the form of good nutrition, hydration, promotion of good hygiene, food and water safety, and regular monitoring of growth and development of these children, and timely immunization are all extremely important. Adherence issues in children is by far the most challenging, I can say, but the most important aspect as well, because like I have been stressing all along my talk, these children depend on the adults, and the adults and the child need to be counseled regularly to ensure that adherence does not suffer. We need to counsel them and ensure that the timing of the ART does not clash with the timing of the child's school or college, and it does not clash with the timing of the adult caretaker's work timings, because we want that mother or father or whoever that is to be there in front of the child and ensure that the child is following these medicines. And as far as possible, the timing should be made common for all the family members, so that each of them can draw motivation and monitor the timing of ART as well. Age-appropriate disclosure in every single child with HIV is very, very important and has to start as soon as possible in a step-by-step manner, and it is an ongoing process. It improves adherence to the medicines, it reduces the psychological stress, and leads to a better engagement in HIV-related care. So partial disclosure without naming the virus can be begun as early as 5 to 6 years of age, depending on the understanding and the inquisitiveness of the child to know about what drugs and why he needs to take it. And the full disclosure about HIV needs to be completed by the time the child is about 12 to 14 years of age, ideally. In the last 2.5 decades of my practice in children with HIV, there have been n number of excuses and n number of barriers for proper adherence in these children. It's really, really sad. Many of them have so many different reasons why they cannot stick to their regimen, and they have to depend on adults, and there are financial constraints and no one to accompany them, and a whole lot of that. But despite all these challenges, we as care providers for these children should make a heartfelt approach. We should empower our little kids to understand and believe that antiretroviral therapy is a friend for life. So make the child understand that every single day, no matter what, you have to take these medicines and be accountable. They'll definitely learn that for life. We have to help them establish a disciplined daily schedule so that the child's nutrition, the child's studies, the child's hygiene, the child's ART intake, the child's sleep, everything is taken care of right from that. This is a small implementation which I started in 2005-06 in the orphanages that I have been associated with. We give these golden books to these children and ask them to learn accountability for taking a small little young age. A child who cannot even read and write are given colorful bindis to stick every morning and evening after taking the ART, just to establish that accountability for taking their drugs. And the same child, as he grows up and learns to make a sleeping line, standing line, smiling face, star, put initials or put proper signatures, they all learn accountability right from that age itself. And also for the occasional errant teenager, they end up motivating them and bringing them back on track. So ART can definitely work miracles, like you can see in this child here. In a matter of 3 months, this child has transformed into a beautiful, happy, cheerful little girl. ART has definitely revolutionized the outcomes for children living with HIV. But the persistence of this virus in the child's system, as well as the exposure of the antiretroviral drugs over a lifelong period, leads to chronic persistent inflammation, chronic persistent immune activation, and a propensity to non-AIDS defining comorbidities in the form of cardiovascular complications, neurocognitive impairment in these children, metabolic complications and malignancies. All these things need to be kept in mind, and we need to monitor and tackle them as and when they do occur. So antiviral therapeutics in the old form also has seen a lot of revolutionary changes, nanoparticles, missiles, patches, 3D printed dosage form, whatnot. All these have been helping for improving the adherence, the challenge of adherence in children. And of course, the promising long-acting antiretroviral injectable drugs now hopefully will really be made available soon, and all our older children and adolescents can go on it. So as pediatricians, we have an immense kind of a responsibility spanning across the entire critical growth and development period of these children infected with HIV. So right from the newborn period, right through their infancy, as well as toddlerhood, their childhood and adolescence, and transition to adult life. So we have a huge span of nearly 18 years in front of us, where we need to make proper changes and ensure that these children are on track and are biologically suppressed. So we have come a long way. In the late 80s, when we used to see children like this at Gujarat Children's Hospital in Mumbai, where we had severe complications, CNS manifestations and slim disease, to now, where we have children who are perinatally infected and grown up, and got married and have children of their own who are HIV negative. We've definitely come a long way. And on behalf of all these thousands of children, I would like to say, despite having come a long way, we still have miles to go in terms of getting acceptance in society, dependable healthcare systems, job opportunities, educational opportunities, opportunities to get married, to learn life skills and responsible parenthood, legal support, safe, secure, supportive environment, care and counseling that has to be ongoing, enabling and empowering platforms for our future progress and growth, and networking opportunities, and of course vocational training and income generation, so that we can become self-reliant and stand on our own feet. So it's not important only to concentrate on the medical management of HIV in terms of keeping these children alive and healthy on antiretroviral therapy. It's equally important for us to ensure they have an opportunity to grow up and blossom into productive citizens of the country. Because we have to remember, every positive child has a right to a positive life. These are the 2 books that I have published for pediatric HIV. And these are some visuals of the recently concluded Trans-Africa driving expedition, which I did to sort of spread awareness and promote support for children with HIV. Thank you.
Thank you, Dr. Lala, for the excellent talk. We'll take questions for the discussion at the end.
After hearing the very good session on current perspectives in ART in children and adolescents, now we move to the next session. Questions will be taken after the completion of the. So next topic is the challenges in transition from pediatric care to adult care. The speaker is Dr. Vinay Kulkarni from Pune.
ASICON welcomes Dr. Vinay Kulkarni. Dr. Vinay Kulkarni holds leadership positions at Prayas Health Group in Pune. He is an expert in bone dermatology and HIV medicine, showcasing a unique combination of specialties. Dr. Kulkarni's areas of expertise include PMT, and pediatric adolescent HIV medicine, highlighting his dedication to vulnerable populations. He has a strong educational background with MBBS, MD, DMD, FAMS, DINA, and AHIPS qualifications. His involvement in various aspects of HIV medicine suggests a commitment to both research and education in his field. We look forward to hear him talk on challenges in transition from pediatric care to adult care.
Good morning, Dr. Mamatha. because the last slide, what she said, is what I was going to talk about actually. So, challenges in transition are basically going from being cared for by someone else, our parents or caregiver, to caring for self, and that is the transition of the journey. And what I am going to do is not going to give you a lot of data and kind of things, but its own experiences, and so I think most of you might have actually seen some of this previously also. So Prayas is my organization. We work on 4 major verticals, and behind that 4 verticals is whatever material we have prepared, and it is all accessible. It's in the public domain. There are a lot of videos, there are a lot of books and everything on our website prayaspune.org, and recently we have done something like 112 videos, which are very small videos, about 40-50 seconds, about all these issues about understanding the children want about sexuality, amaze.com, and we have them on our website. So talking about bullying, talking about self-image, or talking about discussing, everything is there. So our efforts so far have been because of, as was told, I was doing a mother-to-child transmission project for a very long time, 2001 to 2019, and we screened something like 16 lakh pregnant women. We had almost 4,000 of them HIV infected, and then we reached to a lot of, we prevented a lot of them because we had, I think, only around 50 transmissions out of them. But because we had this contact with these families, we had a lot of children who came to our clinic at that time, and we had hardly any pediatricians who were treating. So unfortunately, as the HIV physician, I had to treat everyone. So children living with HIV, then we have adolescents, we have children, adults, and I think the same subject when I was presenting last year or year before that in Mysore, I had said that it's not HIV infected, perennially HIV infected children, it is perennially HIV infected adults now, because many of them have become 35, 37. So this was our journey, like this is our journey. There was no ART, there were deaths. Then in 2000 we started our child care program. We started providing ART, children started surviving. 2004 we transitioned all of these children to free ART, and then in 2010 when these children become adolescents, we felt that this was the first generation of children on the earth probably who was transitioning to adulthood. We had no prior experience of having children who are growing into adolescence, and so we started doing some workshops for these children. And we felt that when these children are growing around 2014-15, there was a lot of lack of understanding about emerging needs of these children. So there were coverage gaps in terms of ART uptake, linkage to psychosocial services, ART adherence and comorbidities, and about the nature and burden of psychosocial issues. So we started a study which was called as SAMIN, Survey and Mapping Initiatives for Linking Wild HIV to Medical and Social System, and we are reaching out to adolescents and youth living across Maharashtra to understand the current status about their physical, mental and social well-being and support them to get linked to needed services. So basically, because we were children, what we had to do was to contact their caregivers because we couldn't directly access them. So those who have earlier participated in the workshops, the children, through organizations and through friends and partners of ALHIV connected to us, we trained counselors to initiate discussions with the caregivers. First contact person was either caregiver, but when the children were older, more than 18 years, they were the children also, and a verbal consent was obtained, and so far we have approved more than 1600 ALHIV successfully, and we have connected with 915 of them. So they have now in our virtual platform where we interact with regularly. So mean age right now is 23 years. The gender wise, there are 60% of male children and 40% female children. 74% of them are unmarried still. There were 24% were married, and HIV status of the partner was in 82% cases. HIV partner was living with HIV, and 18% were HIV negative. So profile, many have reported that they have single parent or have lost both parents, so many of them are orphans. Many have reported that education status is below 10th or 12th standard because they could not complete their education. And except 4 cases, all of them reported they are linked to an ART center or taking their treatment regularly. But it means that beyond 18 also there are many children who are not yet on treatment. The concerns of the caregivers with whom we talked was still, and she was talking about disclosure at a very early age, and we are talking of adolescents and adults, and parents have still not disclosed their status to the children. There is a girl who is going to a medical school. She comes with the parents, and I am surprised that she doesn't ask any questions. Every time the father, mother, and the child, of course, the child must be knowing, but they come to the clinic. As soon as the examination is over, the mother and child go out, and the father discusses everything with us. So the disclosure is a big problem, and unfortunately now, when they are adults, we can take their consent and to them because it is their right. But when they are below 18, we have to keep on taking consent from the parents to disclose. And these have been children who are on treatment for more than 10, 12 years. So I don't want to disclose now. He is just a school-going child. He is preparing for 10th standard this year. Let him finish the exam first. I will decide about it after the exam. But this is going on since the 4th standard. And now he is in 5th, 6th, 7th, 8th. Now it would be next time it would be 12th. And the other concern the parents have is marriage of the children, and that we know. Like I am a dermatologist, and even if there is a daughter who has a small white patch at the age of 2, they would be worried about marriage. So this marriage fixation is also in the mind of the parents, like what would happen, what the questions they would ask, etc. And the next one is adherence, because Ritesh has left school, he gets angry, irritated all the time. Now he says that he will not take the tablets. To calm him down, I have to hold his hands and legs. I don't understand what to do now because he is not taking medicine. And it is said that there is not a single adolescent or parentally HIV infected child who has been 100% adherent till the age of 18. 100% of them have been non-adherent some time or the other. And so there are problems with the drug adherence as well as treatment. But at the same time, when we contacted them, many of them said that we need these kind of spaces where we could discuss these issues with someone, and they had this space when they came to our clinic. They felt they need a safe and secure space where their confidentiality is taken care of. And what were the concerns of the adolescents? I lost my parents in childhood. My uncle did not educate me because I have HIV. So this consent among the parents themselves that this child is not, why educate, why spend money on that? So they don't educate them. Stigma and discrimination still exists at the schools and colleges and institutions. So that is a major hindrance. Stigma hinders the job opportunities. Many of these children, when the first thing they don't have education, then they don't have capacity, then they don't have jobs, and then they need some livelihood opportunities. Marriage, of course, is on the mind of all these children, and this is the one which always they keep on asking what would happen if will they get a partner. The girl has proposed me, but I have not responded to her yet. I am afraid that if she learns about my HIV, she will leave me. So it is not only about the marriage, but the friendships also. So among close relationships, when to disclose to the friends and all the usual issues in the society about caste, religion, etc. exist in spite of HIV infection. Like it is not easy for us to leave the caste and get married with the caste. If we marry her out of the caste for the sake of HIV, we may be thrown out of the caste. So we have a huge list about around 130, 40 children in our clinic, and we try to match them whenever there is an opportunity. But all these other issues also are there. It's a very interesting story that I had a mother-to-child transmitted girl. She is now 37, 38 years old. That time back when she had come, she came from a Raipur district of Chhattisgarh, and the parents came to me and said, we want you to find an upper caste kind of a fellow from Raipur area for this child who is I said, I'm not going to go around with the shoe of a Cinderella, like finding out a match for that, and kind of a thing. And interestingly, but I suddenly remembered the story. She did her LLB, then she did her LLM in London, where she found a fellow from Spain who was HIV negative, and she is now settled in Madrid and is a professor of law. So now, when that fellow from a white fellow from Spain proposes, they don't have this upper caste Raipur fellow. They don't want that kind of a thing. So, of course, I don't understand where to find a positive girl. There is an organization that is asking for 15,000 rupees to share the proposal. So there is a kind of an exploitation also going on. Disclosure in the relationships is an issue about for these children. We can find a girl from our village, but we have to tell about the status, so what to do about it. Non-disclosure takes many forms, and gender adds another layer. The family members have fixed the marriage. I don't want to tell her about HIV right now. I will tell her once the engagement is done. So then there are discordant things, and as I said, almost 15% of them have married to people, children who are HIV negative also. So ours is a love marriage. My girlfriend was aware of my HIV. It has been a year since my marriage. Now my family is putting pressure on for a child, but the issue is we haven't had sex yet. I have fear that I will transmit the virus to my wife. So all these mental issues and stress is also there. My wife is HIV negative. Now we want to plan a child, but I get scared of this thought. She is not aware of my HIV. We don't know how to disclose it. So disclosure to partner still remains a problem. Mental health issues complicate these issues because I know that my wife was HIV negative at the time of marriage. She got this infection through me. I definitely know that. She was not aware of my status. A couple of times I started the pills and stopped them. I was tired of taking the pills. So non-adherence because of the mental health issues, increasing problems with the couples is there. Then there are fights against stigma at jobs, if they get jobs. So I am a computer engineer. I got a job in a company. During medical test, I was told that you get a HIV test done. At that time, I had to disclose my status. After the disclosure, they did not call me back after the interview for the job. With the support of an NGO, we constituted a committee, sensitized them. The company apologized and called sure they will not discriminate against others in the future because she did not want to go back to the same company for the job. So there were issues of anxiety and depression, and our counselors provided counseling services in person as well as telephonically to more than 90 youths. There were attempts for suicide. So there are a lot of issues through which we are engaging with this youth. Sensitization in the first contact, caregiver specially designed workshops, then virtual community meetings and sessions with them, and of course counseling and referrals to different things. We have to have an integral approach during transition to adulthood because now they are going to be on their own and they have to seek care. So care and support systems are needed, education and empowerment is needed, and need to focus on support systems during transition process. There are some people, like for example in the other countries, there has to be a systematic transition that a pediatrician cannot treat an adult. So they have to have a very systematic thing how the child transitions. But in our country, pediatricians treating the child will have to keep on treating child when the child becomes adult. But a person who has been treating HIV, adult HIV, has to now also keep on treating the children, and we are treating everyone. So we need a lot of referrals. For example, ART, mental health, a lack of access to services due to stigma, lack of skills, so skill buildings, and we are conducting workshops with some of the organizations like lighthouses, etc. for jobs. Thank you.
Thank you for a very lucid presentation, Dr. Vinay Kulkarni. You have very nicely explained the practical challenges encountered in real life during the transition from pediatric care to adult care. So the next speaker I will give it to my co-chair.
The next speaker will talk on mother to child transmission and early infant diagnosis. That is Dr. Kartik Shah from Ahmedabad.
ASICON welcomes Dr. Kartik Shah. Dr. Shah is an additional district health officer in Ahmedabad, demonstrating his leadership in public health administration. Dr. Shah achieved first rank in both his PGD-PHM and PGD-HM, highlighting his academic achievements. His career spans roles from medical officer in tribal areas to state quality assurance medical officer, demonstrating a wide range of experience. Dr. Shah has expertise in various national health programs, including TB elimination, leprosy eradication, AIDS control, and viral hepatitis control. His current responsibilities encompass family welfare, non-communicable diseases, community health initiatives, HIV/AIDS, and blood centers, indicating a broad public health focus. We look forward in hear him talk on MDCT and EID.
Thank you very much. Myself, Dr. Kartik Shah. Actually, the government of Gujarat created the post of public health officers about 3 years back, and I am the first public health officer in that batch. I think out of in whole India, only 2 or 3 states are there where public health officers posts are there. So I am one of them. I am looking after government setup from last 26 years. And I have worked in a primary health center, community health centers. I have also looked after the district health and from administrative from last 16 years. So administrative part I know very well. I am a public health specialist. Maybe clinically that much I may not be able to answer your questions in that sense. But from public health expert, I can explain you each and everything regarding this program. Because I have worked as a district program officer in HIV/AIDS in 2008-9 at district level also, and at present I am holding the state level post. So about mother to child transmission, in the beginning the word was MTCT. MTCT means mother to child transmission. Later on the word came as PPTCT. As we know that mother is infected maybe by spouse or by husband, that was the reason why the second word was coined, that was PPTCT. Later on EMTCT came, there is elimination of mother to child transmission, and at present we are having the word as EVTHS. EVTHS means elimination of vertical transmission of HIV and syphilis. As you all know that NACO 5 itself, the word has started with STD, National AIDS and STD Control Program in NACO 5. So we are also focusing on syphilis. And we had a new module of EVTHS last year only, in about November 2024. So we are dealing in pregnant women, HIV as well as syphilis. So these are the main objectives of the program. First one is HIV/AIDS related, HIV/AIDS prevention and control. Only 1 year is left to achieve these objectives. The objective is 95% of people who are most at risk of acquiring HIV infection use comprehensive prevention. Second one is 95% of HIV positive know their status. 95% of those who know their status are on treatment, and 95% of those who are on treatment have suppressed viral load. So at present we are focusing more on this 95, 95 and 95. In Gujarat state we have achieved 86 and 97 clear. And we are hoping that we can achieve this 95 till the 31st March of next year. The third one is 95% of pregnant and breastfeeding women living with HIV have suppressed viral load towards attainment of elimination of vertical transmission of HIV. In Gujarat, we have been given the estimate of 1,121 pregnant women that we are supposed to find out. Out of that, till yet about 679. So it means that the cases are also in a decreasing trend, and that is also going in
our data also. We are having 0.01% decline in this year. So the last one is less than 10% of people living with HIV and key populations experience stigma and discrimination. Same way now we are focusing on STI also, STI and RTI prevention and control. For that, universal access to quality STI and RTI services to at-risk and vulnerable populations. Attainment of elimination of vertical transmission of syphilis. So we are doing much work or much more focus on this EVTHS. That is what we are focusing, and even NACO has asked us to have more focus on this EVTHS. So now why EVTHS is important, or why we should go for, we should take the mothers for each and every routine transmission, and why we should focus more to mothers, that is the important thing. So about HIV/AIDS transmission and dynamics, you can see the proportion of infection is by sexual route, blood-borne route, injecting drug users, or from mother to child transmission. So mother to child transmission is approximately 3%, and chances of infection, if you see from mother to child, that is 20 to 40%. Even though we all know that blood-borne transmissions are chances of infection are more, as it is 95 to 99%, but from mother to child also there are 20 to 40% chances of infection. At present we have reached up to 5%, so we need to go below 5%. If you see the data of one of the biggest medical college in Ahmedabad, or maybe in Gujarat, or maybe in even India also, in last 7 years they have not a single child having HIV positive, even though the mothers were HIV positive. So that is the focus on us. That is the things we are doing it. At present also we are having 2 ARD centers in Vijay Medical College. Both are catering services to around, first ARD center is catering services to around 5,000 people, and another one started with 780 patients are already enrolled there. So we are focusing on zero transmission from mother to child. Now about mother to child transmission. Transmission from HIV infected mother to baby is the key mode of HIV transmission in children. Annually about 14,000 new HIV infections occur among children in India. Out of them, in Gujarat it is around 1,100, and we have the decline rate. So we have found out only 600 patients who are HIV positive. Mothers are HIV positive, not children. HIV infection causes about 10,000 deaths annually among children in India. It is possible to prevent HIV infection among infants and children. Currently available antiretroviral drug regimen, I have brought the regimen and drugs also with me. Nevirapine is also there, Zidovudine is also there, and also dolutegravir in pediatric dosage is also there. That is provided by Government of India, NACO, and we are able to achieve the target of zero transmission in our pediatric patients or infants. Now, how these children get the infection? So, HIV transmission from mother to child occurs mostly during pregnancy, labor and delivery, and also breastfeeding. Major factor that increases the risk of MTCT is amount of HIV viral load in the mother's blood. So we are trying to achieve 100%. All the mothers, we take the blood and send for the viral load testing. We have 4 viral load testings laboratories available in Gujarat. So risk of HIV transmission during pregnancy it is 5 to 10%. During labor and delivery it is 10 to 15%. During breastfeeding it is 5 to 20%. As our mothers are coming from low socio-economic status, we are supposed to tell them that you continue with the breastfeeding, and many times it is possible that the viruses are transmitted from the breastfeeding. Even though most of the viruses are not transmitted through breastfeeding, but it is possible that it can be transmitted. Overall, without breastfeeding, it is 15 to 25%. Overall, with breastfeeding up to 6 months, it is 20 to 35%, and overall with breastfeeding for 18 to 24 months, because many times in tribal areas, mothers breastfeed their babies more than 2 years, so it is 30 to 45%. Now, what is our goal? Our goal is to eliminate new pediatric HIV infections, so it should reach up to zero level. This can be done by improving maternal health, newborn health program, child health and survival in the context of HIV. So we are in the contact of NHM, and we are also giving the services to RMNCAH plus N through RMNCL program. And in that also we are having the dual kits available for testing of HIV as well as syphilis from the ASIC program. In EVTHS program, elimination of vertical transmission of HIV and syphilis, the program is based on 4 prongs. First prong is that we should have primary prevention of HIV. So person should not be infected with HIV. So patient or female or mother should not be HIV infected. If the mother is HIV infected, we should try that she should not be pregnant, and it is the need that she may be pregnant. So the third prong is we have to prevent the HIV infection from mother to child. So there is a third prong. Even the mother is HIV infected and pregnant, then we should try that the baby should not be HIV positive, and for that CSD, care support and treatment, we give HIV infected mother and child treatment as well as single dose nevirapine or nevirapine as well as need of the zidovudine. Now about the key process indicators targets for last 2 years, that is 95% of all estimated pregnancies registered at ANC and have at least one ANC checkup. At present we are doing 4 ANC checkups at each and every session. We are doing Mamatha session and we are also reporting that in NACO software. 95% of all estimated pregnant women needing PMDCT know their HIV status, and 95% of all estimated HIV positive pregnant women are alive and on ART. We are entering this data in source portal. The day before yesterday also we talked about this source portal, and each and every mother is entered in that. We are also taking the data from HMIS software, and whoever the pregnant mothers are there, these pregnant mothers are, as per the government of Gujarat circular, termed in very high pregnancy, and the government of Gujarat has circulated that all HIV positive mothers, maybe they are having AIDS or not, they are to be delivered in either medical college or at district hospital level. So impact indicators are HIV population, case rate of new pediatric HIV infections due to MTCT of less than or equal to 50 per 1 lakh live births, and HIV MTCT rate of less than 5% in breastfeeding countries or less than 2% in non-breastfeeding. For about syphilis, case rate of congenital syphilis of less than or equal to 50 per 1 lakh live births. Now what are the interventions that will help our babies to be born without HIV? That is primary prevention of HIV in childbearing women. Provide HIV information to all pregnant women, that is done by our counselors at ICD centers. Antenatal visits are opportunity for PPDCT. Prevention of unwanted pregnancies in women. Prevention of PPDCT through ART centers and safe obstetric practices. So what are the safe obstetric practices? Interventions during labor and delivery. Minimal vaginal examinations should be done or minimize the examinations. Avoid prolonged labor. Use oxytocin to shorten the labor. Avoid premature rupture of the membranes. Use patogram. We have Lakshya program, and in the program also we are strengthening our labor rooms, and there we use patograms. Avoid artificial rupture of the membranes. Do not use suction unless absolutely necessary, and early cord clamping after it stops pulsating. Even though it is directed as delayed cord clamping, but here early cord clamping after it stops pulsating and after giving the mother oxytocin. Avoid unnecessary trauma during delivery. Use non-invasive fetal monitoring. Avoid invasive procedures. Avoid routine episiotomy or support peritoneum. Minimize the use of forceps or vacuum extractors for all infants. When head is delivered, wipe infant's face with gauze or cloth. After infant is completely delivered, thoroughly wipe dry with a towel and transfer to the mother. About newborn care, immediate newborn care, do dry warm, clear airway, cut cord with new blade in adequate light, initiate breastfeeding within 1 hour, and antiretroviral prophylaxis to the baby as prescribed. Do not use mouth operated suction, that is what is needed. Do not do nasogastric tube suctioning in the newborn unless liquor is meconium stained. Mode of delivery. In India, normal vaginal delivery is recommended unless the woman has obstetric reasons for a cesarean section. Even though cesarean section is recommended, but here normal vaginal delivery is recommended. Use of ART can reduce risk of mother to child transmission. Interventions during infancy. Observe for signs and symptoms of HIV infection. All HIV exposed infants should receive cotrimoxazole at 6 weeks of age. follow standard immunization schedule, routine well baby visits, early infant diagnosis and 18 months. These are the main things which we do for PPD-CD services. Lifelong ART to all HIV positive women is recommended. HIV positive pregnant women, pregnancy in an already known HIV positive women, newly diagnosed. ARV interventions. HIV exposed infants. Exclusive breastfeeds up to 6 months is recommended, and gradual weaning after 6 months and introduction of complementary feedings from 6 months. ARV prophylaxis for infants. I have brought zidovudine as well as nevirapine. That is given to the babies. It is available. And this is the latest chart on the basis of this. We recommend our medical officers and our staff at the counselors at the PPD-CT or at the ICD center to counsel the mothers and to babies. If all of you are sitting here, maybe they are postgraduates or maybe specialized persons, maybe I am also a public health specialist, but we are catering these services by medical officers, and all the medical officers are catering the services to around 80,000 population in Gujarat. 80 to 85,000 HIV positive patients are being treated by our medical officers, and we give them this type of protocols so that they can give the services to the HIV positive beneficiaries, whether it is a mother or a child. Early infant diagnosis also we do tests. Day before yesterday also they told about we take the DBS on 6 weeks, then 6 months at 12 months, and as well as on the after 1.5 years. So our goal is no child should be born with HIV, no child should die because of HIV, and no child become an orphan because of HIV. This should be our goal. Thank you very much, and for help all our members. Thank you.
Thank you, Dr. Elimination. A nice presentation on mother-to-child transmission and early infant diagnosis. The last topic in this morning session is HIV and menopause. I invite the speaker, Dr. S. Poongulalai from Chennai. All the questions and...
ASICON welcomes Dr. Poongulalai Selvamathu. Dr. Selvamathu leads the clinic operations at the VHS Infectious Diseases Medical Center, demonstrating her administrative and management skills. She heads the HIV and Women's Program, focusing on preconception, antenatal care, after pregnancy, and prevention of mother-to-child transmission. Her expertise includes reproductive health of women with HIV, screening for gynecological malignancies, menstrual health, postmenopausal care, and infertility treatment. Dr. Selvamathu's research interests include prevention of cervical cancer, treatment for HPV, vaccination, and behavioral research related to gender issues in HIV-infected women. She has over 15 years of experience in HIV and AIDS prevention, treatment, and research. We look forward to hear her talk on HIV and menopause.
Good morning, everyone. I want to thank my colleague Beulah for the beautiful introduction that she wrote in a short time for me. I think the session has actually come full spectrum from HIV in infants, children, and reproductive age group to HIV and menopause. So we all know that the reproductive age of a woman starts typically from the onset of the menstrual period to the end of the final menstrual period, between which we call the reproductive age of the woman. And towards the end of these years, the perimenopausal ages start, and from then to once the final menstrual period happens, and after that we have the postmenopause. So by 2030, the WHO estimates that around 1.2 billion women all over the world will be postmenopausal. And India, recent analysis of the data show that 15% of currently married women. This is very important because these are actually reproductive age women who are having a high percentage prevalence of menopause, and most of these were in some pockets surgical menopause. And like we all know, the advances over the past 2 days and 2.5 years, we've been hearing about how ART has impacted the life of people with HIV over these many spans of years. We heard people telling us how they have seen in their real-time practice how this has changed over the years. And now we know because of this increasing life expectancy, and which is almost near normal to that of a person without HIV. HIV negative women, women with HIV, as of HIV negative women will spend more than 1/3 of their lives living in a postmenopausal stage. So many data groups have started looking at women transitioning through menopause, which is you see there is a shift in the group of women that are going through, an increasing number of women who are perimenopausal or postmenopausal. This is from the Swiss HIV cohort study. If you will see this kind of grey bars are the ones which show the increasing number of women in perimenopausal. And if you look at when it displayed in change into numbers in the ages, you will see there are more groups of women in this group of women are 40 to 60, which is typically the perimenopausal and the postmenopausal women, or typically women transitioning through menopause. So when it comes to HIV, there are two main things. One thing is, what is the age of menopause in women with HIV? Because there are, I think it started with Clark's study which showed that women at 40 have anovulatory cycles. So there's been an increasing conversation on this, where what is the age of menopause at HIV? Does it happen earlier, or there is increased incidence of premature ovarian failure in this group? And interestingly, this study, and most of these are self-reports. So this study looked at biochemical validation and a self-report. So they used follicle stimulating hormone levels, which is a typical indicator for menopause, and they used it along with a self-report. And this is in a group of women with HIV and women without HIV. And so when they looked at it, you will see that actually there was no difference in the women with HIV and the women. Both of them seem to be transitioning through menopause at the same time, both in the biochemical group and in the self-report questionnaires group. So there was no statistical difference, no specific HIV-specific variables were associated, like CD4 or viral load were associated, or ART was associated with age and menopause in this study. But interestingly, they did see early menopause in a particular group of women, but this is in both the women with HIV and without HIV. And this was one important factor in both these groups of women was current tobacco use. So another important conundrum in HIV is prolonged amenorrhea, because we know HIV affects the pituitary and multiple glands, and it's a chronic inflammatory state, and it's a chronic infection. And so typically there are many studies on showing the effect of HIV on the hypothalamic pituitary axis and the pituitary gland itself. And so there is a history of prolonged amenorrhea in these cases, which is on self-report can be taken as menopause, which is actually not menopause. If you look at it, women with HIV had around 24% of prevalence of prolonged amenorrhea as against women without HIV who had only 13.3%. And this study from the subgroup in a sub-study from the reprieve looked at, interestingly now, increasingly more studies are looking at AMH and inhibin levels as markers of reproductive aging rather than menopause, as against the typical cessation of menses. So this divided women into three groups. So one which had the normal AMH with normal menstrual cycles, some which have lower AMH with regular cycles, and other group with low AMH and no menses. So this is the postmenopausal group. So the cardiometabolic correlates that they found in this group was obviously greater chronologically, the older the women, higher waist circumference of more than 80 meters, a hemoglobin of more than 12 grams per cent, and residence in some low LMNCs like Sub-Saharan Africa and other countries. Because reprieve was a study in middle-aged women more than 40 with mild to moderate cardiac risk. So what actually happens in menopause? Most of the effects are due to estrogen depletion. The problem in women with HIV that estrogen depletion and HIV replication both act in similar pathway to increase gut permeability, increase immunoactivation, and increase inflammation. We all know symptoms of menopause occur across all these domains. Mostly we've heard of the mood swings, hot flashes. I remember in one interesting Netflix series, Pooja Bhatt sitting and swallowing ice cubes when talking of hot flashes to cool herself off. So this is and vaginal dryness. These are the common things that we see. So what happens in women with HIV in this group? I think the bottom line is that we must understand that women with HIV go through almost the same symptoms. And what's the important factor in women with HIV, these symptoms are more severe and more frequent and more pronounced than in women without HIV. So this is just describing the spectrum of symptoms in the premenopausal, perimenopausal, and postmenopausal women. So most importantly, we should note that most of these symptoms seem to start in premenopause itself. They persist through perimenopause, and there's some of these symptoms like the somatic, the exhaustion, the vaginal dryness, and all these seems to get aggravated postmenopausal women. So 1 in 5 HIV, women with HIV in the prime study had severe menopausal symptoms as opposed to women without HIV. And when you go to the symptoms, I just wanted to go through a few of them, not all of them because of lack of time. And I'm sure there's an overlap of many things. So this is a study that looked at issues in sexual function in women with and without HIV. They compared two cohorts. This natural was a cohort of HIV, women without HIV, and the prime cohort was obviously looking at patterns of menopause in women with HIV in UK. If you look at this, the whole group, both these cohorts of women reported almost similar problems and insects. But most importantly, women with HIV had a lower function. They reported more than one problem lasting for more than 3 months. The vaginal dryness was more common. They were more common to report anxiety, arousal, and anxiety. Most importantly, they had more significant association between HIV and this sexual symptoms, which is 53.3 versus 38.2% in the group without HIV. And the musculoskeletal symptom, I think we all know, we've heard of it enough, it's been enough studied. And HIV infection and menopause can have a dual pathway effect on the bone, and sometimes some ART drugs also can have a additive effect on this, leading to trabecular bone loss and so many other things. So fractures are more common, osteoporosis is like 3 times more common, fracture prevalences are 1.5 times higher, and HIV infection and menopause are independently predictors of lower bone mass density and have an additive effect on the lumbar spine and the total BMD, which means these two sites should be more closely monitored. And interestingly, a study on the periodontal disease activity showed that women with HIV had more teeth loss. They had more than, most of them had less than 20 functional teeth, which is needed for proper dentition and function in postmenopausal age, and there were increased marks of bone resorption. Just to say that these group of women, it's not only important that we look at the bone and the heart and other things, it's also important that they take care of their teeth. So we all know what are the drugs that are linked to this bone health issues. We know tenofovir has been tried many times and convincingly convicted of causing bone issues and renal issues. And there is enough evidence by now to show that switch from tenofovir to TAF can cause bone recovery and in most of these patients. And amongst these many combined regimens, the TAF plus dolutegravir regimen has been more studied and seems to be the more favorable one to the bone. So while having said that, this interesting study which looked at switching of women in the menopausal age group from other regimen to integrase inhibitors. If you see, there is an interesting caveat in this study. You will see that this orange line is the group of people who are having who have switched in the perimenopausal or the late perimenopause. You can see a huge sudden swing in the BMI and waist circumference in this group as compared to the women without HIV in the same age group and the women who were not switched to integrase inhibitors. So integrase inhibitors may be favorable on the bone, but we do not know they seem to have severe obesity-related metabolic issues, especially when they switched in the perimenopausal period. And this is a cohort, this is a sub-study from the RIPRI, which also showed the same thing. They compared to men, and women had a higher BMI and a higher waist circumference. But interestingly, the RIPRI study showed that this difference was not associated with the difference in any metabolic parameters like glucose, LDL, or metabolic syndrome or hypertension. So but maybe as of now, TAF blood PTG will be the most favorable with probably a good monitoring of all these things. And we all know women with HIV in the perimenopausal seem to have more cardiovascular issues than the women without HIV. And subclinical atherosclerosis is one of the markers for this cardiovascular events, which is actually measured by the carotid intima media thickness. So in this study, you will look at, there is an analysis comparison between the women with and without HIV and in the during the menopausal transmission. If you look at this time, there's an accelerated increase in the slope, whereas you will see the slope going up slowly. So in the women with HIV, there is a greater accelerated progression of the intima medial thickness in this group, probably associated with the depletion of estrogen in this group. And there's a greater progression probably associated with greater CVD events, and this should be closely monitored for. And also metabolic dysfunction associated hepatitis. These seem to be of a low prevalence in women with HIV, but once menopausal transmission starts, the fast course seems to go very high, and probably menopause may exacerbate renal disease in this group of women. Menopause and depression has been hugely studied. We all know menopause causes mood swings, depression, but does it actually have an impact on viral outcomes? So this study looked at viral blips, low-level anemia, viral fevers, low adherence. Though there was a little issues with women who needed psychiatric group, but eventually the study showed that though they had difficulties, they remained virally suppressed, and this depression through menopause did not affect viral outcomes or HIV-related outcomes in this group of women. And also interesting, this study showed that there is an increase. We know women with HIV can have more stress. Women with HIV and menopause can have even more stress. But this study looked at the connects between the increased TNF-alpha secretion because of the estrogen withdrawal and the connections between the medial prefrontal cortex and basically looking at the limbic systems involvement in this stress perception. And this showed that in postmenopausal women, probably these pathways act to actually cause an increased perception of stress rather than the actual stress that they have. So what is more important in this is that we know that women with HIV live with symptoms, postmenopausal symptoms similar to women without HIV, but as part of regular care, these are very rarely addressed or even inquired upon. So you will see in this group that only very few women were actually asked about their menstrual or menopause related symptoms unless it caused an issue, not as a routine clinical care. So what are the recommendations to improve health outcomes? Lifestyle modifications, we've heard of them enough, exercise, weight-bearing exercises, supplements, calcium supplements and vitamin K2, and there are lots of studies about magnesium supplements coming up, proper and appropriate mental health support, peer support groups, improved access to hardwood, and most importantly, the mainstay of treatment is personalized hormone replacement therapy or menopausal hormone therapy. So menopausal hormone therapy, the baseline not contraindicated with women HIV. We do not have a huge experience because less than 10% of women are actually using it. We do not have data on DDS, but with reason integrase inhibitors, not much of an interaction. But we do not have data on the CVD, but we do not have data on women with HIV associated with venous thromboembolism risk. But still, menopausal hormonal therapy is indicated as the cornerstone of treatment with any postmenopausal women, and usually should be starting in the perimenopausal period because the earlier you start, the more the benefits. As demonstrated is one interesting study which showed that use of MHT in subclinical cardiovascular disease in women with HIV and without HIV. You see the slope is this orange slope is the women who have ever used HT or they were on HT, as opposed to the group that had never used HT. This was from the WIS cohort, and they showed that there was a lower risk of progression in the carotid intima median thickness in the group that had ever used, even in the past or past users or currently using. And there were very low serum D-dimers levels surprisingly in this group because we know that hormonal therapy has been traditionally associated with risk of thromboembolism and other cardiovascular risks. And these are the non-hormonal treatment that are available. And this interesting study recently published showed that they did a oophorectomized immune reconstituted mouse, and they tried a beta-accepted probiotic, and they showed that it can reverse changes in the bone. And so the bottom line of treatment, the bottom line is that we're going to see more women with HIV going through menopause. We need to understand that hormonal therapy is needed and should be identified and started early so that they can get maximum protective cardiovascular, bone health and other issues in this group. And last but not least, we do not want to leave the men behind. Andropause is one thing that, andropause is true, men lose like 1 to 2% of their testosterone every year starting from the age of 30, causing various other issues. No data available on that. Thank you.
Thank you, madam. Thank you. Appreciate that. So very comprehensive and lucid presentation on HIV and menopause by Dr. S. Punadulli. Now already we are running 15 minutes behind schedule. So we entertain only 3 to 4 questions on these 4 topics. Any questions from the floor?
Dr. Mamatha, many of our children are doing well and they are studying. Yes, they are in higher. Many of our students, positive children are doing well and studying. They are in higher studies. You didn't advise any thing to prevent metabolic disturbance and dyslipidemia for these children?
Well, lifestyle modifications like
As according to adults.
yeah, the same thing. But then we need to also remember, see, many a times there is a misconception in the minds of people, even our own parents and grandparents, we see that children are allowed to eat anything. When they become big, they'll be careful about not eating junk food or not eating chips and this and that. The foundation has to be right from infancy, because the fat cells are laid in that stage of life, and they are only going to accumulate more fat and not increase in the number of cells that we know. So we need to have proper lifestyle, modifications right from that age itself, especially in the context of HIV positive children, and ensure that they eat healthy and have enough physical activity and have a positive outlook in life, and of course regular monitoring for antiretroviral therapy.
Some of our children are suffering with dyslipidemia, raised cholesterol, raised triglyceride levels. Treatment is same as adults, or
it's the same as adults.
To Dr. Lala, I had a doubt. Mother-to-child transmission through breastfeeding. So, child takes breastfeeding into the milk goes into the stomach, right? Stomach is having a lot of hydrochloric acid. How a feeble organism like HIV will survive in that concentrated hydrochloric acid?
So the risk of transmission from breast milk in a baby is more when there are cracked nipples, or there is a blood contamination, and there are oral ulcers or candida in the child, and anywhere along the GI system, if there are micro abrasions, then that can be a sort of a place from where the HIV virus can gain entry into the child's system.
But HIV is a very feeble RNA protein. It will be easily digested even in the salivary enzymes and in the gastric enzymes. So this possibility of nipple cracks and ulcers in the mouth may be very rare.
Well, we have enough evidence to say that breastfeeding is a very, very important mode of transmission postnatally for children. If the mother has a high viral load, she is not on antiretroviral therapy, her virus is not well suppressed, and she continues to give breast milk to the child, as long as she is breastfeeding the child does have a potential risk of getting HIV infection through breast milk alone. Yeah.
Thank you. Any other questions? There are no questions. Yeah, please. Dr. Kumar Swami.
Just to follow with this on breast milk transmission, you saw the data from government programs.
Actually,
the breastfeeding countries, they have a higher transmission as compared to non-breastfeeding. It very clearly shows, the studies have seen, our antiretroviral therapy, does not get into the breast milk to suppress the virus. There are studies showing there is a dissociation between plasma viral load and breast milk viral load. Because of this, we might continue to see some transmission through breast milk. I am not recommending to stop breastfeeding or anything, because that prevents a lot of other diarrheal diseases, malnutrition, so on, and things like that. So here, to your question on how we transmit it, because breast milk does contain HIV, despite having antiretroviral viral load plasma, and if there are any cracks or any other mucosal transmission, still can happen. And that's the only way that we're able to prove that despite having antiretroviral therapy, 95% of virological suppression, still the transmission happens in countries, breastfeeding countries. That's the only thing we're able to look into that. We do not know the current generation drugs penetrates all these barriers. Maybe we may need other therapies to suppress the virus even in the breast milk, similar like in CNS.
Thank you, Dr. Kumar Swami. So if there are no questions further, we will wind up the session with your coach's permission.
Yeah, thank you everyone for attending the session, the speakers for giving us the talks.
Sir, I want to take your 1 minute. I want to applaud and give, I want to congratulate our fellow, Dr. Janak Soni. Please stand up. He is a Joint Director CSD here, and they are giving services to about 80 to 85,000 people. So whenever there are problems related with ART or drugs, anything, they are managing it. So please give a round of applause to him. Please two medical officers are also with me. Dr. Savan Rao. He is a medical officer, ART Center at Sola Medical College. And those who are doing private practices here, I have seen the MD physicians. I was working in tuberculosis program before this. I have seen MD physicians taking government services, like bedaquiline is not available, pretomidine is not available. They are taking, being MD physicians still they are taking treatment from our government setup. So any patient, any having problem, just refer to him. He will take care of the patients. Please give a round of applause.
Thank you.
And Dr. Aisha Organized is also there. He is one of the biggest medical college SPP, private, corporation setup. She is also giving good services to our HIV positive cases. So any thing needed from our side, let us know. We are four are there in Gujarat. Thank you very much.
Thank you, Dr. CAPRISA.
Thank you very much. I would like to request our chairperson to present token of appreciation to our speakers, Dr. Mamatha Lala. Dr. Kartik Shah. Dr. Lala. I would like to